Good morning. This is a very special occasion for me. I'm very excited to host Professor Steve Pelton here at Rambam. I'm thankful, very thankful for everyone who joined us this morning, and a special thank you to Professor Ron Dagan, who has honored us with his visit from Soroka, and is actually responsible for all of this because he introduced between Steve and me 10 years ago. I apologize from reading from a paper. I was worried or expected that I would be very excited and this will make my tongue tied, so I came prepared. Steve Pelton recently celebrated 50 years at Boston Medical Center. He's a professor of pediatrics and epidemiology at Boston University School of Medicine and Public Health. He is the former chief of the Pediatric Infectious Diseases Division, a world-known researcher on pneumonia, pneumococcal disease, vaccines, otitis media, and more. He was a pioneer in treating children with HIV when many other physicians refused to treat these children of fear from an unknown fatal disease. He led multiple clinical trials. He is the head of the Maxwell Finland Research Lab and has been honored as a top doctor by Boston Magazine for now 11 years in a row. For the fellows, Steve was definitely the favorite attending to make rounds with, I can say it here, and one of the best teachers I've ever had. Steve, you taught me the most important lessons in life: compassion and empathy, forgiveness to others and not less important to ourselves. You taught me about growth and humbleness, persistence and patience, friendship and true partnership. You are always respectful and genuinely accepting people for who they are, regardless of their title or background. You showed me what pure kindness is. You taught me what teamwork is, how to work hard and play hard, and how to enjoy a glass of a crisp, cold white wine at the end of a long day, or a cup of hot chocolate on those cold, snowy winter days in Boston. It's obvious how much of my path and choices are inspired by you, and I'm forever grateful. I hope my home here at Rambam will be welcoming as the home you gave me at Boston Medical Center. Thank you.
Not quite sure how to follow that. Boker Tov. It's a pleasure to be here. I've been looking forward to coming to Rambam for more than 9 years, since I've heard so many stories about the wonderful place that Rotem trained at and the wonderful people that she's worked with. And I hope that my days here I'll meet more and more of her colleagues and have a chance to get to know them. I thought today I would talk about a topic that I know something about, pneumococcal disease and pneumococcal vaccine. And I took the perspective of looking at the disease and the impact of vaccine in the United States and in Israel, since both Ron Dagan and myself have been conducting surveillance studies on pneumococcal disease and the impact of pneumococcal vaccine for over 20 years. And I hope you'll get to see some of the contrast between the way the disease has evolved over the last 2 or 3 decades. These are my disclosures. What I want to talk about today is pneumococcal disease in the era of the 13-valent pneumococcal vaccine, the nasopharynx and PCV. Not all pneumococci are the same. The impact of COVID-19 on invasive pneumococcal disease in children, and the persistence of serotype 3 despite PCV13. So the first slide I put up shows almost 2 decades worth of experience. On the left side is the US, on the right side is Israel, and in both countries you can see the decline in invasive pneumococcal disease that follows, especially after PCV13 is introduced. In the US, we use a 3+1 regimen. In Israel, you use a 2+1 regimen. If you look closely, you'll see that in the U.S., disease declined by nearly 80% between 2010 and 2021. Whereas in Israel, disease declined by about 40% between 2010 and 2019. If we dig a little deeper and we look at pneumococcal meningitis, and I look at that specifically because, at least in my concept, it's the most severe form of pneumococcal disease. You can see the dramatic decline in the U.S., where we went from approximately 1,000 cases to less than 200 cases, or about an 80% decline, first in children less than 2, and then subsequently in children 2 to 4. And if you look at the experience in Israel, you also see a decline, but again, a decline of about 40% compared to the U.S. 80%. So if you just looked at the two slides I put up, you might say, well, that 3+1 regimen is a lot better than that 2+1 regimen. But you'd be wrong, because that's a simple and incorrect conclusion. But you need more data. And so here is the evolution of what we call replacement pneumococcal disease, which is the rise in invasive pneumococcal disease due to serotypes not contained within the vaccine. And if we look at the U.S., you can see the decline in vaccine serotypes in purple, and similarly you see the decline in vaccine serotypes in purple in Israel. And both the 2+1 and the 3+1 regimens have been very successful in reducing vaccine serotype disease. But if you look at non-vaccine serotype disease, on the U.S. it's in yellow, and you can see there's not really much increment. On the other hand, if you look in Israel, you see a different story. You see an increase, a doubling, maybe even a tripling of disease due to non-vaccine serotypes. And this is one of the dilemmas of the past 2 decades, is understanding why in some places non-vaccine serotypes are an important cause of invasive disease, and in other locations they're not. Whether it has to do with climate, whether it has to do with microbiome, whether it has to do with environment, pollution, is to me unclear, and I'm hoping to ask Ron for his thoughts about this at the end of my talk. Dr. Lapido and I published a paper about IPD syndromes in children under 5 years and how much disease was averted over the 20 years in the United States that we've been using vaccine. And you can see quite an impressive number. 172,000 cases of bacteremia, 55,000 cases of bacteremic pneumonia and empyema, and 16 or almost 17,000 cases. Of course, the goal of the vaccine is to prevent morbidity and mortality. And indeed, in the U.S., we estimated that 2,000 lives were saved over that 20-year period of time from pneumococcal conjugate vaccines. The second lesson I learned is that not all children are at equal risk for IPD or alveolar pneumonia. Again, if you look at the left side of the slide, you see recent work that Dr. Lapido presented at ECMID, and it shows invasive pneumococcal disease in children that have commercial insurance and comorbidity in the solid blue line, or Medicaid insurance and comorbidity in the solid red line. And you can see quite dramatically that children with comorbidities have much more disease than children without comorbidities, especially in the first year and 2 of life, but actually throughout childhood. We also looked at the difference between those that are insured commercially and Medicaid, where Medicaid is a proxy for children with lower socioeconomic status. And we did find some difference where children with lower socioeconomic status had slightly more disease than children who are commercially insured. If you look on the right side, you see the difference between the Jewish population and the Bedouin population, and you see it's obvious that there's more disease in the Bedouin population. So again, within different countries, different groups are at greater or lesser risk for invasive pneumococcal disease, and not all children are the same. Two of the important comorbidities that we identified was one, asthma. And I point this out because asthma, at least in the U.S., is the most prevalent comorbidity in childhood. And even if the relative risk is not as great as if you have cancer or immune deficient, the fact that it's so prevalent in the community makes the burden of invasive disease in asthmatics a very important part of the burden of disease. And what you see here is that depending upon the severity of disease, you have increasing rates of invasive pneumococcal disease and increasing relative risks, both in children less than the age of 5 as well as children 5 to 17. Another important fact that we identified is if you have multiple at-risk conditions, diabetes, pulmonary disease, cardiac disease, the more conditions you have, the greater the risk. And indeed, if you have 3 or more at-risk conditions, you have a greater risk of having invasive pneumococcal disease than if you have immunodeficiency. So when we look at who's at risk and who needs special attention in our community, I think the two underappreciated comorbidities have been asthma and the multiple at-risk conditions, or what we call risk stacking. The nasopharynx and PCV, we all know that invasive pneumococcal disease starts by acquisition of the pneumococcus in the nasopharynx. This is a slide I modified from Ron showing the two ways in which pneumococcal vaccine prevent disease. One, by direct protection, where they create circulating antibodies, opsonophagocytic activity, and they prevent invasion of the bloodstream, or if invasion occurs, it's quickly cleared. But the second, and maybe equally important, is the fact that they prevent colonization, or I used to believe they prevent colonization. Now I think that there's data that I'll show you that suggests that they reduce the density of colonization, and therefore they reduce the transmission of pneumococci within the community, preventing disease both in underimmunized children as well as in unimmunized adults. So if you look at pneumococcal carriage, again, on the left is children in Massachusetts that we survey over this period of 13 years. On the right is Israeli children that Dr. Dagan surveyed. And you see very similar themes. First of all, the prevalence of carriage is the same over this 13-year period of time in Massachusetts children. And the prevalence of carriage is higher, but it's the same over time in Israeli children. You also see that the color coding in the bars change, and so the distribution of serotypes changes. Originally, if you look in 2001, you can see that there are PCV7 serotypes, PCV13 serotypes, and non-typable serotypes. By the time you get to 2014, it's almost all non-typable serotypes. So even though the prevalence of carriage doesn't change, there's a redistribution, and you see the same redistribution that occurs in Israeli children. So why does the redistribution of serotypes result in a decline in disease when you have the same amount of pneumococcal carriage within your community? And again, this is our data from years of study of carriage. You can see that this is a heat map. The darker the blue, the greater the prevalence of carriage. The vaccine serotypes disappear over time with the introduction of PCV7. However, 19A and actually 7F increase over time, and then with the introduction of PCV13, they decline. But look at the increase in the non-vaccine serotypes, it's quite dramatic and multiple different serotypes. So why acquiring different serotypes, how does that prevent you from getting pneumococcal disease? And the answer is that not all serotypes are the same, and not all serotypes have the carriage to event ratio that is similar. And as an example, if you look at 19A, which is a quite virulent strain in the Boston community, about nearly 15% of children have a carried strain, and that means that nearly 5% of children in Boston were carrying a 19A, but 40% of disease was due to 19A. On the other hand, if you look at a strain like 11A or 23A, where nearly 10% of children are carrying a strain, or 10% of pneumococci that are carried are those serotypes, you see almost no disease identified by the black columns. And what we've learned is that there's a mathematical concept called invasive capacity, which relates the number of events of invasive disease that occur related to the carriage rate. And what we found is that different serotypes have different invasive capacity, and what we replaced with the vaccine, which was the vaccine serotypes, were strains that had, in general, larger invasive capacities with strains that had lower invasive capacities. So just redistributing the strains results in a lower rate of invasive pneumococcal disease, including pneumococcal meningitis. And this concept of reducing the transmission of virulent strains is important. Usually we talk about how valuable it is for preventing disease in adults, but sometimes we overlook how valuable it is in preventing disease in children. So again, this is data from Dr. Daigan's group, looking at the decline in disease in infants less than 4 months of age. So those are children who've only had a single dose at most of PCV and are not protected by eliciting enough antibody to be protective. Yet you see the decline in disease over this 15-year period, especially once you introduce PCV 7 or PCV 13. Similarly, if you look at otitis, you find the same decline in the less than 4-month-old group, and this is herd benefit as opposed to direct protection, and it demonstrates the value of herd protection within the pediatric community. So where do these serotypes go, these vaccine serotypes? Do they disappear from the community? Do we have to worry about them in the future? Well, I put up some data here from Belgium, where they had a significant problem with serotype 19A. They were using PCV10 vaccine, which is a 10-valent vaccine that doesn't have 19A, has 19F, relies on cross protection, which doesn't actually exist. And in the early phase, when they switched to PCV13, they saw a dramatic decline in 19A disease. And basically 19A disease disappeared. About 70% or 75% of the kids were getting PCV13, and they decided to switch back to PCV10, probably because it was, one, less expensive, but mostly because it's a Belgian company that makes the vaccine. And as you can see in the slide, right away we saw PCV13 now only administered to about 3% of the children, and a dramatic rise in disease due to 19A. This actually shows carriage, but disease followed. And on the other side of the slide is work we're doing in Boston, looking at carriage of pneumococci. And what we've learned is that the vaccine serotypes often cannot be detected by culture, but they can be detected by molecular technology. And a good example is serotype 3, where in this group of children we found 8 children who were culture positive, but we found an additional 6 children who were only detected by molecular serology. And if you look at overall, if you look at the vaccine serotypes, we found 18 children in our community in this study of about 160 children who were culture positive, but we found more children who were culture negative and carrying a vaccine serotype based on molecular studies. So I think that the concept that they're gone from the community is incorrect. The concept that the vaccine eradicates them is incorrect, that it reduces their density, it makes them much less likely to be transmitted, but if you stop vaccinating, they show up in the community. And this was recently presented at ESPID by the German group, looking at what happened in Germany during COVID. And the dark blue represents the period of time from June 2022 to March 2023, and the PCV serotypes increase following the COVID pandemic. And the explanation from the presenter of the paper is that they had a rather marked decline in the uptake of PCV13 during COVID, and what came back was the vaccine serotypes. So they don't disappear from the community, they're there, and there's a need to continue to immunize against them. Not all pneumococci are the same, we've talked about. What happened during COVID? Dr. Lapido presented our data recently, or in combination with myself, at last the International Symposium on Pneumococcal disease. And what you can see here is that over time, between January 2020 and December 2022, there's a dearth of invasive pneumococcal disease. And when you look and try and understand why there's a dearth of pneumococcal disease, what you see is that there's no RSV detected in our community in Boston. And Ron published actually much more elegant data looking at the absence of community-acquired alveolar pneumonia and bacteremic pneumonia during the same time period, and the absence of both RSV and influenza, and then the return of RSV and influenza, and the return of community-acquired alveolar pneumonia and pneumococcal bacteremic pneumonia. So what we learned was the link, which we had known epidemiologically, but this really, I think, provided definitive evidence about the link between viral respiratory disease and invasive pneumococcal disease. And if you look at the human model to try and understand, this is a human challenge model that is done in the UK in adults, what they find is two things. One is, and this happens to be a challenge model with a vaccine serotype and the live attenuated influenza vaccine rather than influenza itself. First of all, you find that the density of carriage is much greater in those individuals that get a live attenuated influenza vaccine compared to those that just don't get or get placebo. And second, the explanation over time is that there's a delay in clearance as well. And the delay in clearance, specifically with influenza, has to do with the delay in recruitment of neutrophils, which are critical for clearing pneumococci, and therefore between the higher density and the delay in clearance, there's increased aspiration of pneumococci and increased potential for developing pneumococcal pneumonia. Persistence of serotype 3, a vaccine serotype that is still a major problem both in children and adults. This is data from the US and from Israeli children. In the left side, the green represents serotype 3 disease, and you can see that indeed the vaccine was introduced in 2010, PCV13, and there's no evidence that there's a decline in disease, except when COVID comes. Similarly, in Israel, the yellow bar represents serotype 3, and again, some fluctuation, but no evidence for a prolonged decline in serotype 3. When Dr. Lapido was in Boston, she published a paper looking at our experience over a decade with serotype 3 disease. And again, what you see is the fluctuations, but when you actually analyze it, you find that following the introduction of PCV13, there's no impact on serotype 3 in terms of the incidence of invasive disease. And if you look at the children who are getting serotype 3 invasive disease, you see that the majority of them represent cases that are fully vaccinated. So despite full vaccination, meaning in the US 4 doses of vaccine, they still succumb to invasive disease due to serotype 3. And Dr. Lapido was working on why that problem persists and what's different about serotype 3 than the other pneumococci. So how does the vaccine work? Well, the vaccine creates anti-capsular antibody, which when meeting the serotype of interest, enhances the deposition of complement, which leads to attraction for opsonophagocytic cells like macrophages and neutrophils, and clearance from the bloodstream or the middle ear or the lung. Well, Dr. Lapido has been looking at flow studies to understand deposition of complement in the presence of anti-capsular antibody. If I can just take this for a minute, the y-axis is the deposition of C4, which is critical for the classical pathway. The x-axis is the deposition of C3, which is critical for enhancing opsonophagocytosis. Figure 1 on that's your left is complement alone. And you can see that there's some binding of complement C3 to the cell, no C4 in the absence of antibody. When you add anti-capsular IgG for this is a 19F strain, you can see both an increase in the y-axis or C4 deposition as well as an increase in C3 deposition. And when you block the classical pathway with magnesium EGTA, you can see that there's no longer any C4 deposition, so there's no longer classical pathway activity, but there is C3 deposition, showing that for 19F you can get alternative pathway antibody-mediated C3 deposition. So when we looked at 4 different serotypes, 19F, 19A, 6A, and serotype 3, we found, lo and behold, a dramatic difference in serotype 3. You can see at baseline for 19F versus after exposure to anti-capsular 19F antibody, a dramatic rise in C3 deposition. Same thing for 19A, same thing for 6A. However, when you look at serotype 3, you see in the presence of anti-capsular antibody that there's no increase in C3 deposition. So this is the challenge, is that the current vaccine either doesn't elicit sufficient amount of antibody to achieve this, or indeed there are other mechanisms, other reasons why serotype 3 is resistant to the activity of anti-capsular antibody. I want to close by talking about the implications for extended valency vaccines. What I put up here is the evolution of serotypes in the US over time and in Israeli children over time. And if you look at the pre-vaccine era in both groups, they're more similar than different. They may have different ordering of which serotypes are important, but indeed they're the PCV7 serotypes in general. But if you look over time, there's a divergence in the U.S. from Israeli children into which serotypes become most prevalent in the community as a cause of disease. You can see in Israeli children, 12F, 15B and C, 24F, 19A become the most dominant by 2014. Whereas in the U.S., we don't have 12F. We don't have 24. We have 15BC, 22F, 19A, 33F. So we have a divergence here. And that's probably part of the reason why we have a difference in replacement disease, is that there are different serotypes in the Israeli community than there are in the U.S. community. But why they're different in the two communities, at least to me, remains without a good explanation. Again, this shows serotypes over time, and again it shows that the Israeli children in 2018 and 2019, serotype 8 and serotype 12F are the two dominant serotypes, non-vaccine serotypes in the community, whereas in the U.S., serotype 3 and again many of the non-vaccine serotypes have become more dominant. So what do we expect now that we have a 20-valent vaccine and extended coverage to 7 new serotypes? Well, in the U.S., in children less than 5, this accounts for 32% of the current invasive disease, and when I say current, I mean pre-COVID. When we look at Israeli children, however, Ron has described that they account for nearly 50%, these 7 serotypes in disease, and indeed, in part, it's because 12F and 8 are so prevalent as a cause of invasive disease in Israel and nearly absent as a cause of invasive disease in children in the U.S. But it's more than just coverage that will determine how well the 20-valent vaccine works to address the current needs of the community. And this raises a little bit of concern. What I'm showing you here is the immunogenicity of the 20-valent compared to the 13-valent. And if you notice and you look at the geometric mean ratios, which is the ratio of antibody in the 20 vaccine to the 13 vaccine, almost every one, as a matter of fact, every one, post-3 dose and post-4 dose in the U.S. demonstrates a somewhat lower antibody ratio, so that the 20-valent demonstrates that it elicits slightly less antibody. Is it clinically relevant? Not sure. Is it clinically important? We're going to learn. But it's really a rationale why, without ongoing surveillance, we will be lost to know whether the vaccine achieves the goals that we expect it to. And this has been a point of contention both in the U.S. and in Israel about whether or not the vaccine should be licensed for children. It was just licensed and recommended in the U.S. by our ACIP committee. But they do acknowledge that we don't know what the threshold is for protection and whether these small decrements may or may not be relevant for clinical implications. Let me finish by hopefully summarizing what I've told you. Invasive pneumococcal disease, as well as other clinical pneumococcal syndromes, declined in both Israeli and U.S. children. However, an increase in disease due to non-vaccine serotypes offsets some of the impact, more so in Israel than in the U.S. That changes in the distribution of carriage serotypes result in reduced transmission of vaccine serotypes in the community and the declines in disease both in unimmunized and underimmunized children and adults. That viral bacterial interactions are critical to the pathogenesis of pneumococcal disease and explain both the paucity of disease during COVID pandemic and the recent surge in disease. Serotype 3 persists in both communities despite its inclusion in PCV13. Studies of complement deposition suggest serotype 3 differs from other vaccine serotypes in being resistant to an increase in C3 deposition in the presence of anti-capsular antibody. And lastly, that extended valency vaccines will likely further reduce the burden of pneumococcal disease in children in both the U.S. and Israel. Thank you.